Вітаю, шановні колеги, мене звуть Андрій Varvinskiy, я працюю анестезіологом на Південному Заході Великобританії та у Лондоні. А зараз я продовжу свою презентацію англійською мовою. I have a few declarations to tell you. I have travel grants from Abbott Laboratories. I'm a first author of How to Pass the EDAIC book. I'm a current EDAIC and Royal College of Anaesthetists examiner. I have been invited speaker for numerous congresses. I'm also a MedVoice speaker. Now, let's get on with our topic today. And the first question we need to ask ourselves, do we actually need to learn anything to do with awake fiber optic intubation? Do we have a tool that will address most of our problems? The tool that we've been using since 1943, when Sir Robert Mackintosh invented his Mackintosh blade with the help of his medical technician, Richard Salt, and the whole instrument has been inspired by the Boyle-Davis gag that he saw while he was practicing for a little while in the United States, and we still use this Boyle-Davis gag. So what is the scale of a problem? This comes from the fact that the 15% of surgical population will have Cormac-Lehane view at laryngoscopy of 1, and the majority 78% of 2, which could be subdivided into 2A and 2B, depending on whether most of the larynx is visible or some of the larynx is visible. So it's literally Cormac-Lehane 3 and 4, which constitute as about 6% population that we're talking about. But they are the most difficult patients that we need to deal with, and this is the true test of your ability as an anaesthetist. So what are the indications for awake tracheal intubation? We can subdivide them into two main groups: upper airway abnormalities of any cause without upper airway obstruction and other causes with partial upper airway obstruction. Total airway obstruction obviously will require an immediate action, usually front of the neck axis. Indications might include history of difficult intubation or mask ventilation, anticipated difficulty with laryngoscopy, like anatomical abnormalities, micrognathia, Muffin syndrome, limited mouth opening. Also, indications include pathological abnormalities like upper airway tumors, ankylosing spondylitis, unstable fracture of the neck to avoid neck extension. In a minute, I'm going to show you this slide where you can see that the movement of the neck of this patient is non-existent really. He cannot flex his neck, he cannot extend his neck, he cannot move it up, right or left. This is a case of a severe ankylosing spondylitis. And on this occasion, I managed to get away with just inserting the supraglottic airway device, flexible laryngeal mask, only because this patient had no teeth whatsoever. If he had teeth, even inserting the laryngeal mask would have been impossible. Other indications for awake tracheal intubation include partial upper airway obstruction, when the induction into anesthesia can dramatically worsen the condition, malignant obesity with a BMI of, say, more than 60, burns, jaw fracture, Ludwig's angina, and classically a full stomach includes an indication for awake fiber optic intubation. This probably is the safest method of securing the airway in terms of a full stomach, and in some institutions this is still the indication. I'll show you this video in a moment.
Can you swallow for me? Lovely. Okay. Not a lot of runs there. Say E.
Now you can see that this patient is partially obstructed and there's virtually no room there. So putting this patient off to sleep will completely obstruct him, and you may not be able to ventilate him at all. Now, whether you will be able to fiber optically intubate this patient is another matter. And for this patient, I will probably choose something a bit more exciting, something like a tri-tube, which is a really small, interesting tube that we've been using with a specific Yvonne ventilator. Contraindications for awake fiber optic intubation include unwilling patient, uncooperative patient, excessive bleeding in oral cavity, allergy to lidocaine. Most children will be not suitable for awake fiber optic intubation, and usually with children we use this special mask. We send them to sleep with the gas induction, they are spontaneously breathing, and then with using this flap we put the fiber optic scope, small one, pediatric size, into the patient's nose or mouth to fiber optically tube them. We need to consent this patient in an unhurried way, with an unhurried explanation. It is a verbal consent in my country, and they don't have to sign anything. We have developed this leaflet, which is on your screen, which patient can read beforehand if there is time. And usually I say this procedure isn't painful, it's slightly uncomfortable, and I will make sure that I'll give you enough sedation, enough analgesia, and enough local anesthesia to make it more comfortable. And this leaflet includes questions like, what is the way fibre optic intubation? Why might I need it? Will it be painful or uncomfortable? What can I expect? So this patient can read. Before you start, always have plan B, because awake fibre optic intubation can fail. And your plan B could be inhalation induction, regional technique, if it's possible to perform under regional anesthesia, needle cricothyrotomy, or indeed a surgical airway under local anesthesia. I have been in majority of this situation when either for myself or for a colleague, awake fibre optic intubation was abandoned, and we've chosen a different technique. One time it was a regional anesthesia, another time it was a surgical airway under local anesthesia. We decided when we had a look that it is impossible to intubate this patient fibre optically, like I was showing you on the slide where the patient had this extremely severe partial airway obstruction. Okay, methods of awake intubation can be fibre optic or video, using video laryngoscopy. Today we concentrate first on the fibre optic way. What are the types of fibre optic scopes available to us at the moment? They are either reusable, of different companies that make them, or a single use, which is a lot easier. The difference being that there is a certain setup that you need to do before you start using the reusable scope, and I'll tell you later what they are. As a single use scope is ready in seconds, is plug and play kind of thing. You press the button, everything comes up, all in focus, all in white balance, and everything else done for you automatically, so you can use it in extremis very quickly, in seconds. Make sure you provide pre-oxygenation for your patient, whether it will be nasal prongs or oxygen catheter, which is on the left side of the screen, that we have been using for a little while before we have acquired the high flow nasal oxygen machine, which is on the right side of the screen, that provides up to 70 liters of warm humidified oxygen. And it is still possible with the nasal prongs that go in to insert your fibre optic scope in the nostril and only flick out one nasal prong when you're railroading the tube. And the whole procedure will be a lot less stressful for the patient and for you, because your patient will not be deoxygenating. Okay, there are different ways of anesthetizing the airway, and I'm using the technique which is simple and easy to practice. We call it SAGO, spray as you go technique, and usually we prefer the nasal route because it's more easily tolerated by the patient. What is the preparation and in terms of equipment? So you need to set up the stack, and if it's the traditional reusable stack, then you need to connect four things to fibre optic scope. You need to connect the camera, you need to connect the suction, you need to connect the source of light, and load the endotracheal tube on your scope. And then you need to check three things. You need to check white balance, orientation mark, and focus. If it's the single use plug and play, then you don't need to do anything. Remember oxygen. Then you need a mucosal atomization device, which is on your screen. This is how it spreads the local anesthetic nicely at a distance at about 20-25 centimeters. And you need local anesthetic and you need sedation. Okay, let's continue with medications. You need glycopyrrolate. Traditionally, we've been using 3 micrograms per kilogram or 200 mics of glycopyrrolate to dry the secretions. It's not essential. If you don't have it, you can do it without it. We use TCI remifentanil with or without TCI propofol. DAS protocol recommends using just remifentanil. I use both, but I do not increase TCI propofol more than 1. The only local anesthetic you need is lidocaine, and it comes with the phenylephrine mix for the nostril, and then you might need 4% lidocaine and 10% lidocaine, 10% for tonsillophilus, but your main friend is 4% lidocaine that I will then draw into 10 ml syringes with 1 ml with 9 mils of air in it, to that air that will propel my local anesthetic through the scope when we are actually inserting the scope. I'll tell you later the stages. So this is the 5% lidocaine with 0.5% phenylephrine. Phenylephrine is known as Mizaton to most of you, and it's a vasoconstrictor. And the whole point is to reduce the bleeding when the scope and the tube goes through the nose. Okay, so this is how we use it. We just spray it into the nostril. I usually spray both nostril, but actually before deciding which nostril to go, I have a quick look with the scope to see which nostril is bigger. In 70% patients, a right nostril is bigger, larger, but it cannot be assumed. This particular colleague of mine had a left nostril bigger. Because optimization device is this device that I showed you before, we use it to spray on the tonsillar pilus on the back of the tongue. And you can also use 10% lidocaine if you don't have a mucosal optimization device to spray in the tonsillar pilus. It comes with a nozzle that will propel a local anesthetic further down. So there are different ways of obtaining the gag reflex. And then it's 4% lidocaine for the SAGO. And as you can see, I've drawn 1 ml into 10 ml syringe so that it propels the local anesthetic the local anesthetic through the scope. Okay. Now let's talk about the maximum doses. Maximum doses of a topical lidocaine is 9 milligrams per kilogram. So on this slide, you can see that if your patient is a standard 70 kilogram, then your maximum allowed dose is 630 milligrams. In the vial of 5% lidocaine with phenylephrine, we have 2.5 mils, but you can only deliver 2 out of it, so that's 100 milligrams already. If you're using 10% 6 sprays, then it's 60 milligrams. Then if you subtract this from 630, you'll be allowed 470 milligrams of 4% lidocaine, which is 11 mils. 11 mils is the maximum amount that you can give, but in real life we hardly need more than 6 mils. 2 sprays per 3 points, and I use 3 points of spray on the epiglottis, on the vocal cords, and then on the carina. Sedation, if not contraindicated, if your patient is not in extremis, is not in partial airway obstruction, the sedation could be dangerous in those situations. I usually use propofol, as I said, at a TCI, on the TCI basis, target control infusion basis. Propofol, I never go higher than 1 micrograms per mil. And then I play with TCI remifentanil between 1 and 3, usually nanograms per mil, or 0.05, 0.175 micrograms per kilogram per minute range. And I increase it when the tube goes in, because that is the painful bit. Now let's talk about the choice of endotracheal tube. These are the good tubes that could be used, and I use a lot of the tube that is on the right side of the string called Polar. It's nice and soft and easy for patient to tolerate, and it's preformed. So when you insert it, the proximal bit will go up, and it's easy to connect it to the circuit. The tube on the left side is called Glide Ride. This tube got a specific tip, as you can see here, and it's easy to insert through to railroad over the fiber optic scope, compared to the traditional 45 degrees bevel that catches on the arytenoids. However, my best tube, if your patient is really, really tricky, comes from the set of the intubating laryngeal mask or Fast Track, and that is the tube that comes in the set. And the best bit about this tube is this Huber point. I compare it with the pencil point spinal needle. So because the tip of this tube, unlike the traditional 45 degrees bevel cut tube, like your Quincke needle type thing, goes over the scope nice and easy. So that is my best tube that I would use. It became difficult to obtain this tube, but I keep some in the drawer for real emergencies. Right, let's talk about the steps. We first establish the IV access. We give patient oxygen, apply full monitoring. Not essential, but if you have time to give glycopyrrolate, then it's fine. Remember, it takes about 10 minutes to work, so you need to really give it in advance intravenously. Then you spray 5% lidocaine with 0.5 phenylephrine to the chosen nostril. Then I use 10% lidocaine spray at the back of the tongue and the oropharynx, 10 milligrams per spray. Start sedation, and then use 4% lidocaine through the scope. Okay. If you would like to remember in the graphical way, this is the Difficult Airway Society awake tracheal intubation technique. They subdivide it into oxygenate, topicalize, perform, sedate. So most of the things that I've told you about is on this slide. We have developed our technique way before these guidelines came out. However, these guidelines, the authors of guidelines consulted with lots of us, including our institution, myself and my colleagues, when they came up with this recipe. You don't have to follow this recipe, but this is the amalgamation of all different recipes that colleagues use across the UK. There are a few tips I would like to tell you about awake fiber optic intubation. You follow the floor of the nose close to the base of the nasal septum. Avoid the temptation to go between the middle and inferior turbinate, even if the gap looks large. Identify the familial anatomy and advance quite slowly. It's pretty uncomfortable for the patient if you rush through. It's not comfortable. Sometimes there is a mentality, the quicker I do it, the easier it is for the patient. It's not. You need to move in nice and slow. If you're lost, you need to withdraw until you recognize something and work from there. And mentally, I'm asking myself 3 questions. Where am I? I'm in nasopharynx, I'm in oropharynx, I'm in the larynx. What am I looking at? And what will I see next? If you can answer all these 3 questions, you're fine. If you cannot answer, where am I? I don't know. What I'm looking at, no idea. What I'm going to see next, again, no idea. You're lost. Withdraw, start again. Not completely withdraw, but withdraw until you recognize something. And then keep talking to the patient, making sure that your patient is awake and breathing, because the whole point of this technique is for the patient to continue breathing. Okay, now keep the object in the middle of the screen. Give local anesthetics time to work. Increase remifentanil when the tube is when you're railroading the tube. At this step, you apply gel only before the railroading the tube, because otherwise the gel sticks to the tube and the tube sticks to the fiber optic scope, and it will be impossible to insert the tube. Make sure you see carina when you're advancing the tube. Like I'm doing now, my assistant is holding the scope for me, precluding me to push the scope together with the tube down the airway. And after the tube is in, you check whether the tip of the tube is above the carina, you withdraw the scope like I'm doing now, then you connect the circuit to the patient. And this is what we call the 2 points check. You saw it in the airway above the carina, you connect it to the circuit, you confirm the CO2, and then only after that I will then inflate. I will then send the patient off to sleep, and only then I will inflate the cuff of the endotracheal tube. Because if you do it earlier, the inflation of the cuff is very stimulation, and your patient may cough it out. How quick is awake fiber optic intubation? It's pretty quick. Have a look. This is from obviously when it's gone through the nostril already, and this is the massive tumor of the airway, and the whole procedure. This whole procedure with the laryngeal tumor lasted 80 seconds. In the experienced hands, of course. Right. So this is pretty distorted anatomy, quite narrow, but still possible to pass the fiber optic scope. And then we are in the trachea, and then railroad the endotracheal tube. So it can be done in the experienced hands pretty quickly. What are the problems? Equipment costs money. It's not easy to learn, but it's possible. And I think I've done few thousands so far in my career, having it done regularly and obviously obtaining the relevant list. But the problem then comes after you've learned it. How do you maintain the skills? And you need to become an enthusiast, and then you become an expert. So you need to pick up a relevant list, max fax, ENT list, and then we run several courses, which I don't have time to tell you about. You might say, in my hospital we have endoscopists, and they will do it for us if required. But are you sure they're available 24/7? They're all there. You only have a few minutes in extremis. Will they be there available immediately? The endoscopist, remember, is not an anesthetist. Okay, they mainly do GI endoscopists and other type of endoscopists. And ask them when was the last time they performed tracheal intubation. And also, the fact that they successfully entered the trachea with the scope does not mean that they can successfully railroad the tube and insert the tube into the airway. So it's not the answer. You need to know how to do it. I'll give you some example. This is the real case, a dental abscess done by the second-year resident with a consultant. They planned nasotracheal intubation due to limited mouth opening. They used propofol, remifentanil, rocuronium. They had easy mask ventilation to start with. Now, they had comically Hain 3 with direct laryngoscopy using Mach 3 blade. That's what they saw. A nasal intubation attempt. And it should have been as easy as on this video. Obviously, I'm using the video laryngoscope here, inserting the tube first into the nasal meatus, then looking at my screen, and then I'm using this rotational maneuver to point the tip down.
Okay, great, we're in.
And it flies into the trachea. Unfortunately, they were not as successful. They tried through the right nostril and ended up in the esophagus. They couldn't get the tube through the left nostril at all. The second attempt through the right nostril couldn't pass the endotracheal tube at all. Consultant takes over, tries through the right nostril, and ends up in the submucosal space. Decided to give up nasal route, use the air track instead, couldn't enter into the mouth. Video laryngoscope, hyperangulated blade, couldn't insert into the mouth. LMA 3 they put in with adequate ventilation. Then the colleague rushes through from the nearby theatre to help them. And the colleague uses the technique recommended by DAS, which says, if you're successful in putting supraglottic airway device, try to intubate via the supraglottic airway device using a fibre optic scope and entry catheter. Now, what is the entry catheter? It's the ventilating exchange bougie for fibre optic intubation using laryngeal mask or other supraglottic airway devices. It's 19 French, 4.7 of internal diameter, 56 centimeters long. You can put it over the fibre optic scope and then through the supraglottic airway device. Now, what's the point of it? The point of it is that if you just use the tube through the LMA, it will not be possible to intubate that way. I'll show you the steps. The first step is put in the supraglottic device, and the second stage is use the scope via, well, I'm using iGel rather than LMA, and then that leads you straight to the larynx, because the laryngeal mask or iGel just sits above the larynx, so you will see the larynx very easily, very quickly. So the third stage is the scope out, and you put and you leave the entry catheter in. You connect the 15mm connector, and you ventilate your patient. Fourth stage is you take the iGel out and again ventilate your patient. And fifth stage is you railroad the endotracheal tube over the entry catheter. And the sixth stage, you remove the entry catheter and your tube is in. Easy. So that's another reason why you need to learn fibre optic intubation. But maybe a more familiar tool is better. Maybe the video laryngoscopic type of intubation is better than the fibre optic. And this is the first scope, glide scope, invented by the surgeon in Canada. And on the left side, you see the traditional Macintosh, and then on the right side, his original hyperangulated blade, which basically is a McCoy scope in the flexed position. And this is the article as far back as 2018, comparing video laryngoscopy fibre optic bronchoscopy for awake tracheal intubation, a systematic review and meta-analysis. They looked at 8 publications, and then they found that intubation is faster in video laryngoscopy. There were no difference in success from first attempt and no difference in complications. However, there are advantages and disadvantages of awake video laryngoscopic intubation. Advantages is this traditional technique, faster learning, better viewing angle. However, the drawbacks, the disadvantages, it's not possible with a limited mouth opening and requires a lot more local anesthetic and more sedation. I'll show you the video of how it's done by a colleague of mine in London, in Imran Ahmed. This is using air track. Patient is sedated, breathing spontaneously, easy, seconds. Now, this is an interesting data from a Danish database comparing asleep v awake tracheal intubation in terms of scenarios leading to can't intubate, can't oxygenate, and incidence of the front of the neck axis. So they compared patients with a predicted difficult intubation using asleep and awake intubation. And what they found is that with asleep, the incidence of a failed tracheal intubation is 0.36, and with awake, the incidence is 1 to 2%, so it's higher. However, those situations led to 0.75% of can't intubate, can't oxygenate scenario in asleep patients compared to 0.06% in patients which were awake. Okay, and similarly, there were a lot less need for the front of the neck. So if you failed with awake fibre optic intubation, your patient is still breathing, they're going to be fine. But if the patient is asleep and you can't intubate, then your patient may be in trouble. So in conclusion, I'd say there is no universal tool. You need to learn different ways of intubating, particularly those difficult questions. Each anesthesiologist can and should be proficient in video laryngoscopy and particularly awake fibre optic intubation. Both methods allow you to save the situation and complement each other. And here is the article titled Successful Airway Management with Combined Use of McGrath and video laryngoscope and fiber optic scope, so we can use them to help each other. So basically your fiber optic scope is then acting as a bougie when your video laryngoscope is opening the lifting the epiglottis, and then you will railroad the tube over the fiber optic scope. Thank you very much for your attention. On this slide, I'm pointing you to the full video explanation of how to do awake fiber optic intubation on my educational website called Dr. Varvinskiy Anesthesia Education. If you point your phones on the screen using this QR code, then it will lead you straight to this website and you will see two versions. Please subscribe, like, dislike, comment. Thank you for your attention. Дякую за увагу.